Assalamu alaikum and good afternoon. I'm glad to present our next speaker, Dr. Acosta. He is an associate professor of gastroenterology from the Mayo Clinic. He's not just a physician, he is a scientist, an inventor, and an entrepreneur. And I just found that he's a keen cyclist. He co-direct nutrition obesity program and direct also a precision medicine program in the Mayo Clinic. He had more than 100 publications in high-impact journals like The Lancet, Gut and Gastroenterology. His area of focus of research is in precision medicine to treat obesity and finding the right treatment for the right patient. Hence, this talk of one size does not fit all. Welcome, Dr. Acosta.
Thank you so much, Ahmed. I'm delighted to be here. Thank you so much, Dr. Ahmed, Dr. Suleiman. Thanks so much for the invitation. I'm honored to be here. First time in the Middle East, so I'm delighted how beautiful it is and what an impressive meeting. So what I'm going to talk today is what I like to see as the next step. When you're in your clinics and a lot of these barriers that we talk about, like insurance and all those other things, we start moving forward, and then we have all these options. And then we start realizing, I have 6 medications approved, I have 3 bariatric surgeries I do in my clinic, I have countless of diets, we have devices as well. And then we realize that not everything works for everyone. So what we have been doing at the Mayo Clinic in Minnesota, in the United States, is really trying to find out how can we move forward? How can we personalize and bring individual medicine or precision medicine towards obesity, thinking that this concept that the one size fits all is really not working. So I'm going to talk today from our work on phenotypes. I brought you guys some new data about genotypes, and I think for all of you here, you guys really should be thinking about you have your genotype in your population. You're one of the countries that are the most advanced in genotype in your population. So can we take that information and use it in obesity as well, and then use it to predict response to interventions? Before I start, some conflicts of interest, particularly Phenomic Sciences, who license the technology of the genetic test that I'm going to be talking today, and that's a conflict of interest, as well as consulting for many different pharmaceutical companies and receive funding from the National Institute of Health, as well as many different pharmaceutical companies, devices companies, as well as food companies. So we have many obstacles in the obesity epidemic, and you guys have been hearing that for the last day or a day and a half, and we are really trying to know and take a grasp of everything that is going on in the space of obesity. But when we're in the clinic, to me, one of the most important problems that I have is this issue that we have these heterogeneous outcomes. We can see that from trials. The FDA asks us to tell us what's the percentage of patients who lose weight. But then when we look at this on the clinic, and I'm going to prescribe semaglutide, 2.4 milligrams, our new favorite drug, and of course we have many others. But then the patient in front of me, I don't know if this patient is going to be a super responder and going to lose 15% or more, or is going to be a patient who takes the medication for 12 months, has to still pay for that medication, but is going to lose less than 5%. And the big question is, why? We saw that on the trials, and now that when we're all reporting our real-world data, and you guys are seeing in your own patients and your clinic, it turns out we're seeing more of this variability, maybe because of access, maybe because of cost, many issues, but we're seeing very heterogeneous outcomes. And this actually is a big problem, because at a population level, when we want to treat obesity, or as an individual level, I have to pay this out of my pocket, I want to know whether I'm going to respond or not respond, because if I'm not going to respond, and this medication is expensive, or this device is expensive, or this surgery is expensive, or just doing a diet and not losing weight is expensive, I want to know how can I maximize my money, my investment, either as an individual, as a payer, or as a health system. But I also want to increase access. So as we know, there's a shortage of these medications. There's also a shortage of bariatric surgeons. And we have a shortage of patients being treated with obesity. So we need to try to address that. And in our lab, we've been focusing on the heterogeneity of obesity for the last decade and a half. And this heterogeneity that I'm just showing right now with semaglutide, in this beautiful review in The Lancet by Perdomo, Rubino, and all, they actually summarize that basically all obesity interventions, lifestyle, endoscopic procedures, surgery, and the GLP-1s, and every single medication is going to have a heterogeneous outcomes. And we don't know who are these super patients who are responding super well to lifestyle interventions, to medications, or the ones who are not responding to bariatric surgery. So it's clearly that one of the most important challenges that we need to address when we're in the clinic is trying to understand this concept that the one-size-fits-all is not working. So in order to do that, we try to look into obesity classifications, but most of the obesity classifications are telling us who's going to develop a disease, who's going to have an obesity-related comorbidity or disease, particularly towards cardiovascular risk factors and mortality. But it's not really an obesity stratification. If we look at body mass index, or a newer classification such as the metabolic status of a patient, it's just telling me who is going to develop heart disease. But it's not really telling me how do I manage as a patient. So when I started looking at this, we said, well, can precision medicine help us on this? The traditional approach that we look into chronic diseases as moral diseases is that we want to take signs and symptoms, we call them phenotypes, we then call that a disease, we go through these expensive drug discovery programs, and we have highly variable outcomes. The promise of precision medicine for chronic non-communicable diseases, we need to take that disease, break it down into signs and symptoms, and then call them subtypes. Phenotypes, subtypes, or types of obesity. Each one of these types of obesity should have a deep phenotype or a unique pathophysiological explanation. I wasn't here last night when Dr. Rachel Banningham probably spoke about this, but we talk about the pathophysiology of the disease, right? Can we start grouping the obesity based on the pathophysiology of the disease, then go through targeted trials and have better outcomes? So that's the promise of obesity, of the precision medicine. And when I'm in my clinic looking at patients with obesity, I know the trials, I'm reading the literature, I'm going to conferences like this one, I'm learning, I'm hearing, I'm understanding the association between obesity and all these other diseases. But then I think about one patient only, the patient that is in front of me in the clinic. I think about myself as well. The only thing that matters in that moment is what do I do for this one individual. That patient could come with advanced heart disease, type 2 diabetes, and all the obesity-related metabolic diseases, but it could also be in my clinic only with a BMI of 31 saying, doc, there are all these problems in my family. I don't want to gain more weight. I'm struggling today. I don't want to develop diabetes for them to start curing me or treating me. I want you to treat me right now today. So the question is, right now, we're talking only about obesity as a severity with BMI, or we can even take a step farther. I completely agree with Abdel about the percent measuring body fat with DEXA. So fat mass, right? That's how we try to talk about patients, and we classify them based on their fat mass. But the reality is that obesity is way more complicated. And I like to put it in these different domains. We have the energy balance domains, who tells me what I want to eat, when do I want to eat, how much do I want to eat. That is separate than the domain of the glucose regulation. That if I have insulin resistance because I was gaining weight, if I have a predisposition based on what I'm eating to develop insulin resistance, that's going to correlate with my food intake and my energy balance. That's different than the fibroinflammation. For those of us who are hepatologists, we see a lot of fatty liver disease and inflammation. So the inflammation is correlating with this. And then we have the hedonic and reward perspective that drives us to anxiety and depression. So when I'm going to treat my patient, I cannot just think about only the BMI or only the insulin on the glucose, the A1C, or only whether they have fat on, fibrosis on the liver or not, or whether they have depression or not. I need to think about absolutely everything. And then, of course, I need to also think about the social determinants of health, because it's not the same thing to be talking with a Latino like myself or be talking with a white American who have completely different cultures. And the same thing for you guys. So we need to start including these things. And once we start understanding this heterogeneity of obesity, then we can start bringing omics to try to use this as biomarkers. First with genetics, that's what we are from mom and dad. We are exposed to an environment, and that environment is, for those of us who maybe want to go and exercise, we might be exercising a lot, but we might also eat certain type of food and not other types of foods. And that interaction between our genetics and our environment tells us we change also our genetics into epigenetics, metabolomics, and the proteomics. So all these things is what we need to try to address when we talk about precision medicine for obesity. And today I'm just going to tell you about this little thing that we've been focusing called energy balance. But when I'm talking about this, I want you to think that I'm just talking about a subpart of the complexity of this heterogeneous disease. So when we talk about the heterogeneity based on energy balance phenotypes, what we've been doing through the years is trying to understand these energy balance phenotypes in order to understand these traits and separate patients with obesity from normal weight and then within obesity. And how do we do this? When patients come to our clinic or our clinical research units for research, all our patients get a resting energy expenditure. They come after an overnight fasting. And then we measure their resting energy expenditure to know their basic metabolic rate. Then we do a DEXA scan to know their body composition. We collect fasting samples, particularly blood, urine, and saliva. Then we do a radioactive meal with technetium put in the eggs, toast, and milk, and we take pictures for the next 4 hours to see how that food goes to the stomach. We're doing questionnaires to know their appetite sensations in that through the morning. We also do behavioral questionnaires, and then when they're feeling hungry around noon, we actually give them all-you-can-eat Stouffer's lasagna, pudding, or milk, and we ask them to eat until maximal fullness, and we follow them for 2 more hours. So this feeding paradigm, we do now in about 880 patients or more. And what the first thing we did is using machine learning, we were able to stratify obesity in 4 key groups that what the machine told us in a clustering way, completely unsupervised. And the 4 groups were these groups that are with abnormal satiation, patients who eat a lot of calories in one sitting, patients who have abnormal postprandial satiety. They will consume a meal, and within an hour or 2, they want to eat again. Patients with emotional eating, and patients who have abnormal energy expenditure. So I started using this concept of abnormal satiation. I started calling them hungry brain because it's easy to explain to my patients that the problem is more likely in their brain, while the patients with a postprandial satiety are most likely to have a problem in their gut with the rapid gastric emptying and not enough hormones coming out of the gut. So that's why I call them hungry gut. And start separating as the term satiation and satiety usually gets confused in the literature. And in many languages, it's difficult even to translate satiation and satiety, as for many of us, for example, in Spanish, is the same thing. So taking this classification, and we've done a series of randomized placebo-controlled trials that I'm not going to cover all of them, but they're all published here, and you guys can take a picture if you want. So of all these anti-obesity interventions at the level of lifestyle intervention, medications, endoscopic, and surgery, and show that if you do a phenotype-targeted intervention, you can actually improve the outcomes of these interventions, and sometimes even improving to 1.7 to 2-fold increase in weight loss if you do this targeted approach. For example, if you have someone with hungry brain that doesn't feel this abnormal satiation, we develop a hungry brain diet that is basically taking the diet from scientist and physician and nutritionist Barbara Rolls, who talk about volumetric diet back in the 90s. And then we pair that volumetric diet with the time-restrictive eating that is more trending now, and we provide that to these individuals. We did not invent this hungry brain diet. We just used them and combined it. Then we use phentermine topiramate, Qsymia in the United States. I think it's coming with the same name here in Abu Dhabi. And then we have the endoscopic, the V-block, the endoscopic sleeve, or the surgical sleeve. For hungry gut, on the other hand, we have the hungry gut diet, the GLP-1s, the intragastric balloons or gels, or the Roux-en-Y gastric bypass. For people with emotional hunger, we have a behavioral program, a CBT program. We also have bupropion naltrexone, sustained release, and there's no endoscopic of surgery. So it's a little bit of a break, and when I show that to my surgical colleagues, they're like, hold on, we shouldn't do surgery for these folks? Well, I don't think the gut can fix a problem with your reward system. At least we do reward surgery. So maybe we need to think about that. And then for the folks with a slow burn, we only recommend an intense exercise plan with a slow burn diet, and there's no medication, device, or surgery right now approved. But there's a few medications on the pipeline, particularly those with glucagon, that I'm very excited to see how they will perform on these individuals. So, of course, this is super exciting that we can do this, and our patients really like, because we change the conversation about the disease when we talk about phenotypes, and we can improve their outcomes. But we also realize that this phenotyping is not scalable, it's expensive, it's time-consuming, and is limited to very few academic centers. So for that reason, we decided to start embarking in a biomarker discovery program, and we're going to focus predominantly on satiation for today's talk, because that's the program that we're the most advanced. So just to understand one more time what's satiation, when we are feeling hungry, and many of you are probably start feeling hungry getting ready for lunch, we start feeling hungry, eventually we're going to start eating, and when we start eating, we will going to stop. When we say, I feel full and I'm going to stop, that's your satiation. You have reached your satiation. And we measure it by how many calories you consume to reach that level of fullness or satiation. And then once we stop eating, we're going to continue feeling full for a period of time. That's our postprandial satiety. And then eventually that postprandial satiety is going to wane off, and we're going to start feeling hungry again. So this cycle that we have of our homeostatic food intake regulation, we go through it many times a day. Some of us 3 or 4 times a day, depending how many times we eat. So I'm going to focus on satiation right now. So the first thing we did is when we started measuring these things on satiation, in 660 individuals, we saw that patients with obesity consume more calories than people with normal weight, just defined by BMI. So we can go right now to the media and to all of us saying people with obesity consume more calories before they feel full. But the reality is when we look at the range, that's a huge range. We have people with obesity who only consume 180 calories, and some ones who consume 2,550 calories. Huge variability. So we cannot say that everyone with obesity have a problem with satiation. And we ask them to reach maximal fullness. We can still say people with obesity consume 300 calories more than people normal weight. But look at this variability. Patients are all over. So who are these patients on the right side of my screen that are consuming more than 2,000 calories in one sitting of a Stouffer's lasagna that I can tell you for those who have tried is not very good, versus the one on the left side who are only eating about 400 calories. So who are these patients? And so we decided to start looking into that. And the first thing we decided to do, is, as with everything that we do in medicine, is we decide to define normality. What is normal? How many calories is normal to eat in a meal? And next time you go and eat a meal, you should ask yourself, am I eating a normal amount or an abnormal amount? And it's so surprising that something that every one of us, or the majority of the humans in this world, have multiple meals a day. We don't know what's normal. So the first thing we did to try to define normality is we separate women and men. So gender becomes, or sex becomes, the most important biological factor. And then when we measure these, we said that women, the average consumption is 762 calories before they feel full, and men is 1,104 calories before they feel full. But there's a big range, as I showed before. So in order to define normality, we use the interquartile range. And the interquartile range has been used for creatinine, for albumin, for hemoglobin A1C, so it's nothing new here. And we define normality. For women, we said if you eat 894 calories or less, that's normal. And if you eat 1,376 calories or less for a man, that's normal. And of course, any of you are thinking, okay, if I eat 895 calories, is that really abnormal for me? I'll say, well, the same thing if I measure creatinine in my lab. Normal is 1.2. So if you have 1.21, that's considered abnormal. The lab will tell you it's abnormal. Would I jump into that? No. It's very close to the normality. But that is how we define normality. So using this, we start looking into the things that actually are regulating gut-brain axis, and we start looking at these genes that are coming from the periphery. All these signals are coming from our gut, from adipose tissue, and are going to our brain, particularly to the hypothalamus, and telling us when to feel hungry or when to feel full. And you guys don't need to study this or memorize this, but it's basically all these signals, including the GLP-1, the leptin, the PYY, all these hormones that you guys know, are sending signals in our hypothalamus to tell us, stop eating, or start feeling hungry again. So we start looking into this pathway and start doing the genetics of these genes, and we selected 40 genes from this pathway. And the first thing we did is we just analyzed the top hits that were associated with satiation. And then using those top hits, in 483 individuals, which we trained this cohort, 50 individuals we had a validation cohort, and when we had an independent cohort of 110 individuals. And these 3 groups are what I'm going to be talking in the next few slides. We had these 3 groups in order to train these models and then use them for validation. And here's the characteristics of the groups. 483 patients in the first group. The average was between 37 to 44 among the groups. The BMI was somewhere between 36 and 39. Majority of them were women, and the majority were white Americans or European ancestry. And we work with what we have. That's what we have in Rochester, Minnesota. So when we take these genes and we build this polygenic risk score, we take the top hits associated with satiation, and then we try to see whether you have more copies of these genes, of these abnormal genes or SNPs, and then we see how many calories you consume. we can see that you consume more calories. You cannot see it with the pointer. But you can see that the more calories you consume, the more risk alleles, or the most copies of abnormal genes you have. And then when we take this new cohort and we do this validation cohort, we can see that it's not that good in the validation cohort, but still we can see this very nice positive correlation in which patients who have more risk alleles, more genes that are working abnormal or variants, consume more calories. So we took this observation and we used machine learning and artificial intelligence to build a model that actually can take these 40 genes, 40 in women, 40 in men, put all in the one bucket and build a model using artificial intelligence with some advanced techniques using random forests followed by support vector machine learning in order to build a model to predict calories to satiation. So we took this model and we tried to predict calories to satiation, and actually when we tried to predict high calories to satiation, we actually do a fairly good job for a model of genetics, in which in the training cohort we had an AUC of 0.85, in the validation 0.82, and independent testing of 0.69 to predict who will be higher than these normal values. And you'll say, why are you showing me all this data? Well, it was very interesting to see that we can actually bring genetics and predict a common trait of how many calories you consume before you feel full. And now we start thinking, we hear about all these talks about saying, obesity is a biological, pathophysiological disease with a strong genetic predisposition. Well, we're bringing that genetics to these pathophysiological traits. And then when we run this genetic model against things like age, BMI, or sex, there's actually no difference. And when we look at things like fasting glucose or abdominal adiposity, there's actually no difference, which is a good thing, because we build a model for satiation. We didn't build a model for fasting glucose or for adiposity. And then when we take this data in the independent cohort and we actually measure satiation in these individuals, when we predict that someone is going to consume high calories, both for men and women, we actually are doing a good job predicting. It's not perfect, but we're doing a good job predicting the calories, and it's statistically significant for both men and women. And when we look at all the things that matter with our satiation, our stomach size, how our stomach emptying, there's no difference on that. So I'm very excited to say that we have built a genetic score, risk score, that can tell us who is going to have this trait, who is going to consume more calories when they sit in one sitting, as we show here in this independent cohort. But what really matters, that's exciting, that's very academic. We can tell you who is going to eat more calories in one sitting, but you can also ask those things to your patients as well as you can ask yourselves. But what really matters is how we use these in clinic. So this is how we've been using this test. And I'm going to show you 3 different studies. The first one is a randomized placebo-controlled trial with phentermine topiramate extended release at the medium dose 7.5 46 milligrams for 1-year study. And what we did is we wanted to find who will lose more than 15% of total body weight loss, or called responders, with this medication versus placebo. So when you take this medication in a randomized placebo-controlled trial with a similar lifestyle intervention that we're doing now in the trials, the average weight loss in placebo is 4% versus 14% on this medication, and 1 year. But when you separate these individuals by the measured trait, how many calories they consume before they feel full, patients who have a low calorie to satiation or low CTS, they lost 9.2% versus 16.5%. And when you use the genetic model, patients who have the low genetic model, the low CTS GRS, lost 10.8% versus 17.7%. So I was delighted to see this data because we did a similar study in 2015 with only 2 weeks with the same model, with the same CTS, and we show that we can predict response at only 2 weeks. And now at 52 weeks, we can take this medication that in the United States is known to be cost-effective, as unfortunately the price in the United States tells us that semaglutide and tirzepatide, thus far, we're waiting for a newer report, has told us that they're not cost-effective to manage obesity. So now we can take this medication that is cost-effective and get us to that magic number of more than 15%, particularly in this drug, 17.7%, with an oral medication that at this dose is extremely safe with minimal side effects. And that gave us a predictive probability to lose more than 50% with the trait of 0.82 and with the genetic model of 0.71, with a very strong negative predictive value of 90%. Now, moving towards the GLP-1s, of course, everybody wants to talk about the GLP-1s. We did a randomized trial with 121 patients, also placebo-controlled trial with liraglutide 3 milligrams and this was only a 16-week trial. This was sponsored by the NIH, and the study is already published. There is a QR code for the paper. You guys want to read the whole paper. And then we wanted to see whether our test can predict responders or non-responders using the FDA cutoff of 4%. And for LIRA, if you don't lose more than 4% at 16 weeks, we should stop the medication. That's what the FDA is telling us. So we did the study, and in all participants in this trial, on placebo lost 0.3%, on LIRA you lost 5.7%. But then when we look at our genetic test, the patients with a high genetic test lost 3.4%, and those with a low genetic test lost 6.7%. And this is not a typo. We actually were surprised to see this. It was kind of a serendipitous finding that patients with a low genetic risk score actually were the best responders to liraglutide. And it was fascinating to see that we can take a genetic test, and while we have a high score, tells us how you're going to do so great to phentermine topiramate, but if you have a low score, you can do great to a GLP-1. And then that gave us a predictive probability of losing more than 4% of 0.75 with a very strong positive predictive value of 86%. Now, of course, people are talking about LIRA, and many of you are using probably LIRA. I use still a lot of liraglutide, but a lot of people want to know about semaglutide. So we published this early this year in our national meeting at the American Gastroenterology Association in May, and we show a real-world study with patients treated with semaglutide. There were 100 patients who were invited to do this genetic test, and 84 of them replied to our invitation and sent us their genetic data. There was no difference among the two groups, but I just want to highlight that from the 84 patients who returned the saliva sample, 51% of them, or 51 of them, were low gene risk scores versus 33% who had the high gene risk score. And then when we saw the data, we were shocked to see and impressed to see that if you have a high gene risk score and you're treated with semaglutide 2.4 milligrams, you lose 10% at 1 year, but if you have a low gene risk score, you actually lose 19.5%. And if you look at that curve, those patients have not plateaued yet. They'll probably continue losing weight. And it's fascinating to see that at 52 weeks, they have already achieved 19.5%. And if you remember, the trials with SEMA were up to 64 weeks. So it was fascinating to see here, but it's not a perfect test. As I'm showing here the individual data on patients who completed 12 months, you can see that we missed one patient who we said that was not a good responder, but we also misclassify patients who were good responders, and we told them to be test negative. So nonetheless, when we look at the patients who lose more than 5%, is 95% of patients versus 63%, and very exciting when we look at the patients who lose more than 20%, is 55% of patients versus 18%, depending on the genetic test. So now we can take patients who might want to come to us and be treated with these medications, maybe even pay out of pocket, or we're going to ask a payer to tell us to pay. And we can provide a little bit more accuracy, thinking who will be the ones who respond to these medications versus who might not respond to these medications. Because I don't want to spend out of my money, in the United States, $1,200 a month for a year to only go and lose, to have a probability of losing, a probability of 18% to be losing more than 20%. So I think this starts changing the conversation, and we can use this test to really help us find the best responders. And that gave us a probability to losing more than 5% of an AUC of 0.76 with a very strong positive predictive value of 0.95%. So very exciting data that we're delighted to be pushing the boundaries of obesity with genetics and these physiological traits, in this case for satiation. But what I want to leave you all, and I want you to think when you're in your clinics, is that the one treatment fits all is really not going to work. And we're going to have better medications, and I'm super excited about them. But we've also been doing surgery for 3 decades. And we know that even with surgery, not everyone responds. So we need to think that we need to go beyond and really try to find out who is the best responder and how should I treat the multiple options that we're going to have available. Obesity is a complex and heterogeneous disease with multiple different phenotypes. Satiation is a complex trait with a strong genetic predisposition, and calories to satiation and this surrogate genetic risk score predict response to Fentop and GLP-1s. And just to finalize, coming back to this slide, which I think is where we really need to tackle right now, I think this becomes an opportunity to tackle, in which I think if we can start bringing specific tests, in this case, a genetic risk score, we might be able to actually find who will be the best responders, and then make obesity to be the treatment more cost-effective, and at the same time start changing the conversation, hopefully provide more access and reduce the stigma, because we'll be able to change the conversation as we'll be able to explain to our patients, to our family members, or to our payers and healthcare systems that actually obesity has a strong biological condition, that we can measure it and we can treat it. So with that, I'd like to thank everyone in my lab and my collaborators who we're working together, and I'd like to take any questions now or at the workshop during the lunch. Thank you.
Thank you very much. Excellent talk. Question, please.
Yes, thank you so much. I think it is really will revolutionize the way we are actually managing obesity. My name is Shamil Mamari. I'm a family medicine consultant. I have here a question, since you have distributed the classification to like gut, satiety, emotional risk factor. A genetic workup might be just only a small part of it, but I believe that even genetic components will be changed with the environment, which you have already mentioned and classified it to 4 approaches, which I believe that this is the way that genetic as a solo indicator will be a lot of ethical consideration there, and it will be a lot of bias. But do we have this tool which actually combine with the validated tools, questionnaires or whatever, to understand the emotional part, etc., and calculate it with the genetic component in a way that it will guide us in the guidelines to which will be suitable for what, instead of just only separate this genetic component? I'm really interested to know what is your insight on that.
Yeah. So that's a great question. And we have looked into questionnaires alone, and they were not very helpful alone. But now that we're starting to combine questionnaires with genetics and questionnaires with metabolomics and different omics, I think we're starting to understand more the complexity of obesity, of the traits. So I think in the future, what we need to do is have a strong genetic understanding of each one of these phenotypes and have questionnaires or blood markers that we can monitor them through time. And that's where we're going. And right now, we're using questionnaires, particularly for emotional eating, and they work great.
Yeah, so there is a validated tool so far, right?
Excuse me?
There is a validated tools
Yes,
right now, but in research context, not outside that.
Yes, we use validated questionnaires, yes.
Thank you so much.
Question, please.
Thank you very much. Excellent presentation, exciting future looks like. You mentioned in your presentation that this study was mainly in Caucasian, I think, white people. So how valid is this in your Hispanic and in your Arabs in the US?
Yeah, that's a great question. We have actually, this is not published, so it's just I'm going to show you some early data, but we have already validated the calories to satiation trait for African Americans and Asians. Hispanics, we're a mess, right? Because there's a lot of different, Hispanics not really a race, we're an ethnicity, right? So if you have European descent Hispanics, it works like any other European. And if you have more Native American or South Americans or Central America, this doesn't work that well. So that's where I think we need to work more on that, and we're working on that.
And please work on the Arabs in the US as well.
Yes, we need to work more on that. Beautiful.
Thank you very much. Thank you.